Hello, this is Dr. Salem from Brooklyn, New York, about a live raw case from my clinic. Today I have my brother here, doesn't mind me filming. Yes, my brother? It's okay, my brother doesn't mind me filming, I appreciate it, thank you. He came in complaining of a headache. Get closer to the camera. Number one, guys, you need to listen to your patient. He complained of a headache that goes here, the side, told me here, and here as well, and it goes on this side more, here. So first thing you need to evaluate. Part of the evaluation, other than history taking, you look at the head. When I look at the shape of the head, if you see here, can you zoom here? Camera zooms the camera. This is like, see, for me, is little, I would say little inflated here and here. It's more fall. This is a cerebrospinal fluid, guys. He's more. This side is more than this side. But if you go here, it's bigger than you're going down here, smaller on this side. This gives you something in your head, okay? We have a lot of congestion. It could be cerebrospinal fluid, could be the venous blood, whatever. Okay, if I go here, I see the mastoid. The mastoid process, we spoke about mastoid yesterday. Mastoid process here is a little bigger than the other side, okay? Okay, this mastoid, can you zoom? You see mastoid here, guys? You can palpate. We need to build up inspection skills. We need to build up palpation skills. Don't expect them to come overnight. People have different skills. People have different talents, different gifted. The best craniosacral therapist, most famous in New York City, he said it took him 7 years with John Upledger just to learn how to palpate the craniosacral rhythm. But now, because he's patient for 7 years to learn, now he's one of the leaders. Okay, anyway. Now here, the mastoid here is bigger, okay, guys? So what tells me if the mastoid is bigger? I mean, the sternocleidomastoid, okay, and the muscles are pulling more here. Could be more spasm in this side. That's what's giving him the pain here and pain in this area, okay? Then I'm gonna go outside here. This is smaller. Okay, first what I'm gonna do, I'm gonna palpate the sternocleidomastoid on both sides. When I palpate the sternocleidomastoid this side, see, it's hard. It's bigger, it's hard, it's hardened. Whatever the tenderness or no. He doesn't have tenderness because people have different degree of pain tolerance. My brother could be, he's a pain tolerant. He doesn't have tenderness, but still is more spasm, it's tight. Not only sternocleidomastoid, has also spasm here, and the sternocleidomastoid, the scalene as well. I go here is very soft. So what I should do here, I need to relax the sternocleidomastoid, and I showed you yesterday how to relax the sternocleidomastoid. That's number one. I already did it in a video that I showed yesterday in the case of neck and shoulder. Now let's go back to the headache. How gonna treat? First, we need to relax sternocleidomastoid here. The second, more important thing here, and I want to tell you, check the space between the C0 and the C2. There's enough space or no? For him, when I checked him sitting first, was a good enough space. See now? Now, okay, what I check here. When I check here, can you go there or hard? Can you go there, zoom there?
Yes.
Anyway, the right occipital condyle is lower, is more caudal than the left occipital condyle. Okay, how am I gonna correct this myself as Dr. Salem? Bring your right knee up, my brother. Put your right knee to chest, please. Right knee. Pull it with the hands to chest. Pull it up more. Relax. Put your head down and rest, brother. Leave your head in my hand. No. There's not a head in my hand. I want you to relax. Please leave it there. Okay, now, as soon as my brother took his right knee up to the chest, to the shoulder, the right occipital condyle that was caudal in relation to the left, it became more cephalic. Okay, now is overcorrected. And usually when you correct some bony deformity or bony abnormality or bony malfunction, can you change the angles? You can change. Okay, the bony malfunction, what you need to do, you overcorrect like 120% because it has tendency to go back what it was. When you relax, it's going to be to the 100%, to the normal correction. Bring it a little up, my brother. Just now relax and leave it for me. Just relax. Put your leg down. Okay, now when he put his leg down, now it's still corrected 110%. Okay, even just by moving his leg. So I try to normalize the occipital condyle. This is number one. Number 2, check the space between the C2 and C1. Now the space is more bigger now. It's much better now, okay? By just moving the hip and stretching the hip. Okay, what if I want to increase the space on both sides? Little more. I ask him to do both knees up. Take one knee, take the right knee up, please. Right knee up all the way. Stretch it. Okay, can you bring the left knee as well? Great, bring it more. Perfect, now relax, brother. Fully relax. Okay, just fully relax, please. Fully relax, fully relax. Okay, a little more fully relax. Okay, okay, a little more, please. A little more. Can you pull more? Can you pull higher? Higher, 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 higher. Pull higher, 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 higher. Wow, pull higher. Okay, guys, the space was not increasing after he did a little bit. Before showing his leg. Only the space between the C0 and C2 started increasing only after I asked him to pull more and higher. So when you work, don't say I tried and it didn't work. You have to be sure that you're doing the right thing and the right amount, right quantity. Pull more, brother, because my brother is like letter B like me, has letter B belly. Okay, pull it out. Like because your belly bother you, just pull up. Yeah, open out and pull. Wow, this is now create bigger space here between C0 and C2. But notice here now, because the right occipital condyle was lower than the left one, and I tried to normalize. When I asked him to pull both knees now, still the right one is little lower. Little caudal. How to normalize? I'm gonna ask him to pull both, but I want this more. Can you pull this with the right more? Right more, right more, right more. Good job, my brother. Now is corrected 110% and normalizing the condyle space. Improving the space between the knees. He's tired. Bring it down, my brother, now. Relax. Okay, what else can help? If you ask him to alternate knee flexion, both sides, right and left, right and left, right and left, this can help. Okay, now I'm increasing the space now very well between the C0 and C2. That's great. This number 1, you'd have more space there between C0 and C2. Number 2, you need to look at the C2 Spinous process. My brother says it's tender. Is it tender here, my brother?
Yes.
Okay, this tender. Okay, how am I gonna fix this? I'm gonna show you how to do based on Lawrence Jones technique, 120 years old technique. Okay, plenty of research is done. This is standardized, as I said before. Lawrence Jones is standardized in American osteopathic medical schools, both the public government schools and private schools. Okay, for Lawrence Jones, for posterior C2 Spinous process tenderness, either you do flexion or you do extension. But for my brother, I'm gonna do flexion, because the flexion is gonna help me increase the space between C0, which I accept, and C2. But what here too, he has been and the back here. Sometimes he has also tenderness and the right splenius muscle.
Yeah, right.
Okay, so when I do flexion here, I'm gonna stretch the splenius muscle. I'm gonna go change my mind, go to the extension. Come all the way out of the table. Very quick, my brother. Young man, come on here. Out of the table. Yes, move up out of the table. Come on. More. Head out. I cradle his head. I let him head down. Now, brother, you have a tenderness here over C2?
Yeah.
Okay, just relax. Let's assume this tenderness is 10 over 10, okay? Let me know how I'm gonna go. I'm gonna go extension like this. Full extension, midline, and I press. How is the tenderness now?
It doesn't hurt.
Speak loud and clear for the camera.
It doesn't hurt now.
0.
Yeah.
0 pain. So the tenderness over C2 Spinous process when I did extension is 0 pain now, as my brother said. Okay. Okay, the spasm and on the right, the Splenius here and Longismus is also gone. Why? Look at me here. Okay, as I told you before, guys, I'm gonna press when I'm doing extension. This is when I'm doing extension here. I'm doing counter strain technique, Lawrence Jones for the C2. I'm supposed to stay 90 seconds. I don't want to waste my time. That's why I'm talking to younger doctors and doctors who want to learn that if you want to take the best advantage of your time, learn more techniques. The more techniques you know, the more efficient you'll be. How? Now in here, I'm doing counter strain for the C2. I'm gonna take the advantage of the time. I'm gonna do positional facilitated release to help the spasm in the right splenius, right longismus. I'm gonna do also, as I told you before, I'm gonna press in the right parietal loop, little bit here, pressure. This is positional facilitated release 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and relax. This is positional vertebral release. Wow, this is good for the Splenius and Longismus. And at the same time, I told you before, it's modified from dry material technique. If you press on a posterior parietal, if you press it, especially with direction towards the C5, like this, to the transverse, the ipsilateral transverse process of the C5, when you press, you relaxing the smooth muscles of the posterior cerebral artery walls. So you can help my brother in 3 ways. 1, 2, 3. Now, 1, 2, 3. Now I told you before that based on Lawrence Jones, you need to stay 90 seconds. I told you, Jamie, you said that in her advanced counter strain that you need more than 90 seconds because the fascia has tone as well, and the skin and the other tissues, and the people with the chronic pain, they have some changes in the central nervous system and it takes time to adapt. You need more than that, but I told you JMTU came in 2002, but in 2010 some young American physical therapists, Brand and others, had some institute called Jones Institute. They spoke that they said that even 30 seconds or less can help. So I'm going to be enough for now. Come up, down, my brother. Just relax. How is it been now?
Better.
Better or 0?
Better.
Let's say it was 10 over 10. How much now?
It's like 5.
5 is a lot. I have to repeat it. Just relax. Leave it to me. How is it now?
0.
0. Okay, I need to stay a little more. This may be chronic pain. I need to stay a little more. Okay. Okay, counter strain, you can repeat it. Positional vertebral release, you can repeat it as well. Okay. Now relax. Just leave it for me. How is it now here?
Very slight.
Like, give me a number.
10 is the highest.
$100 pain. How much you spend? How much left?
I would say around 6.
No. It was 5 before.
Oh, sorry, like less.
Less. Give me a number.
I would say 4.
4. Okay. When I repeat that a little bit. Now, how's it now? How's it now here? When I press.
Yeah, it's good.
There's no pain?
No.
No pain. 0 pain? Okay. Now, the second thing I want to do here, guys, I'm going to take the advantage here, is the alignment. What I mean alignment, guys? You need to check the spinous processes of all the spinous, the cervical spine vertebrae. See, check C2, check C, okay, this is C2, check C3. Are they in one line or no? Are they the same line or no? For me, it's little rotated. The C2 is if the C2 moved to the left, it means to rotate to the right, okay? So try to fix that if you can. Fix this rotation to the right. Just rotate it to the right. If I want to fix it, I'll do this, okay? Let me do this. Rotate. You can rotate it with the HVLA. And I'm going to go very quick about the HVLA for the C2. HVLA for the C2, guys, look at me. Most important for the HVLA is the angle of force. The angle, if you keep your arm like this, it will be parallel to the floor. This is good for the mid-cervical vertebrae, like C4 and 5, okay? But C1 and 2, you need to have your hand, okay, like this. Okay, creating acute angle with the floor. This for C1 and 2. If you want to go for 6 and 7, you need your hand to be like this. Direction of force for HVLA, for cervical spine. The angle, your forearm parallel to the ground is only for C5, okay, it's 4 and 5. 6 and 7, you should be like that. Okay, you'll be like acute angle going down like this. For the C1 and 2 and 3, I'm gonna go like this, okay? So I'm gonna do little extension. Okay, guys, little extension here. And I'm gonna do, okay, little extension, ipsilateral side bending and contralateral rotation for the right side. HVLA to fix the rotation of C2. I'm gonna take it extension, little bit. It depends on a level. If like C1 and 2, do a little bit extension. The more level, the more range, okay? Then I'm gonna do ipsilateral side bending, also depends on the level. Then I'm gonna do contralateral rotation. Okay, then I'm gonna fix the angle now. I'm gonna specify C2, spinous process is here. Then I'm gonna put this here, the first MB joint of the index finger, MBG, metacarpophalangeal, here, this one. Gonna be here over the facet. Okay, guys, this. I'm gonna take off the slack. I'm gonna fix my angle. This is the angle here, okay? I'm gonna be sure. You need to test before you work. Be sure you're testing properly. How can I test it properly? You look at the patient nose. Look at the patient nose, okay? This is testing. I'm testing my movement. If the nose is rotating, you're doing the right movement. Be careful, you have to do the right movement. See now? I'm testing. This is testing. This is testing. This is testing. Testing. The nose should be rotating. Nose is rotating. Okay, I hit the crack. You hit the crack? The crack. That's HVLA to fix the rotation. Okay, because it was rotated. Wow, now it's in the midline, is aligned. Because it was rotated to the right. If the C2 Spinous process is located in the left side, meaning rotated to the right. Then you go on the right and do it. This I did it with the HVLA. Okay, and okay, you have to review the contraindication for HVLA. HVLA stands for high velocity, low amplitude. Okay, high velocity, low amplitude movement. Okay, now it's better. See, now I'm gonna check in the space here. Now is better. Then I'm gonna check. We did the alignment in the transverse plane. I wanna check the alignment in the sagittal plane. Okay, in the sagittal plane. Yes, sagittal plane. Okay, you have to be sure that the occipital is more posterior to the C2 and the sagittal plane. What if it's not? Look at this. I'm gonna put this here, my hand like that, in here, and the C2 will be here. This over the C2 Spinous process here. Okay, and I'm gonna take this other hand here. Okay, and I'm gonna try to mobilize. I'm mobilizing C2 regarding to the head. I can do this from setting, and I'm gonna take the advantage and do it from here now. Okay, I'm gonna mobilize C2. I'm mobilizing C2 up to align it with the occipital. I'm taking the occipital with me. Look at me, guys. I have two hands. This hand holding the occipital. I'm pulling the occipital and pulling down, pulling cephalic and posterior. The occipital pulling cephalic and posterior. I'm C2. I'm pulling anterior and caudal. Okay, just to align. Okay, it's mobilizing, but be careful. This has to be very careful. Be gentle. Do only 3 repetitions first visit. Now I'm holding the occipital condyles. Very safely. You have to be in a bone, not in a soft tissue. You have to be careful with the carotid arch. Do not compress the carotid arch. You can make the patient faint. You can lower blood pressure, okay? Now here I'm holding the occipital condyle and mastoid. You can hook in the mastoid here. And I'm gonna distract and go posterior. And I'm gonna hold C2 and move it anterior and caudal. Okay guys, 1, 2, 3. 1, 2, 3. There for 3 seconds. 1, 2, 3. And I'm done, and I have good alignment between, can you show here, brother? See now, these are occipital here, and a C2. The occipital is more posterior. Now, I can go how to empty here, this one. Move down, brother, good. How is the pain here now, my brother?
It's not almost there, nothing.
No, nothing, there's zero pain now.
Yeah.
Zero pain when I press.
Yes.
Okay, zero pain here. How is the headache now? You have headache now?
No.
Headache is gone, okay? This is your first visit for your headache, brother?
Yes.
Okay, this is the first visit for the headache, and headache is gone. If you look here, the compression was here, look in the head. His little, this was full and was extended. His little better in the side here. You see that? Was much more full. Here is little full. I'm gonna show you the techniques how to take this fullness away. Move down, brother. Move down, please. Okay, guys. There's a small hole in the skull here behind the ear. Here. I'm gonna put one finger in the hole behind the ear here, and I'm gonna turn this. I'm sorry, brother. Yes, it hurts you a little bit. Yes, yeah. It hurts when I twist. I'm gonna fix the rotation. I'm gonna do like little nags for him. I'm doing this here, guys. This is called I'm emptying. I'm vacating the transverse sinus. This transverse sinus, release the congestion of transverse sinus. I keep this for 1 minute. I'm going to take the advantage of being here. Be sure to fix the craniosacral rhythm. If you don't know the cranial, later on I'm going to teach you the cranial, guys. It's kind of the cranial technique. This is keep it for 60 seconds. I'm going to go to the other transverse process, other transverse sinus, empty the contra transverse sinus as well. Here. Okay. What else I can do here? I'm gonna go in an occipital condyle. Look at me here. This little finger is an occipital condyle of each occipital. Look at my hands here. Forearm should be rested. And look here, just forearm should be rested on the table. And you're gonna approximate your elbows. Sorry, this is here. The little fingers on occipital condyles, the medial aspect. and just approximate your elbows. See, like this? Look at my fingers and my elbows. Just approximate your elbows. No force. You just put your little finger like that on the medial aspect of the occipital condyles of both sides and approximate your elbows. Your elbows approximation. Elbows approximation. You see that? This is called, you're gonna release the foremen magnum a little bit. Go down, my brother. Okay, we have the dura mater. The dura is relaxed, brother. Just relax, fully relax, please. Go a little more down, please. Okay, fully relaxed now, my brother. See, guys, I have to be sitting comfortable. My forearm is in a table fully. Sorry, my paper that covered keeps tearing. I know that. Okay, just 1 second. Sorry for the appearance. Let's work with very practical people. For me, the left now, because I released, did the position of the release for the right side, so the left occipital condyle for me is a little tight. The dura, wraps the foramen magnum, and the dura has holes for all the cranial nerves and major nerves. So just 1 second here, I'm gonna do this. Okay, for me, the occipital condyle is more resilient, more flexible, more coming with me than the left one. So I may need to release the left one first, but this is a foremen magnum release. This is gonna help, emptying the fullness of the head, and you're gonna, enhance the passage and the flow of the craniosacral fluid, the cerebrospinal fluid, sorry, the cerebrospinal fluid, the CSF, foramen magnum opening technique. Okay, now, believe it or not, the left occiput is also released a little bit with me. It's not as before with the stretch. You do this for 1 minute. And here again, I'm with my little finger medial to the medial aspect of the occipital condyles, and I'm going to do a little opening, closing my elbows together, approximating my elbows. Let me keep this. Okay, how do you feel, my brother? Good? Okay, now I released it. It opened with me. The two occipital condyles are much wide as this. It's opened. You can feel it. The occipital condyle come with you, open with you. Every bone in our body is movable, and we can move them. You can manipulate them. Okay, if you like the video, press like. Please subscribe. If you have any question or comments, write it down. I know many people could be the cranial is new for you. I do teach cranial therapy if you want. It works wonderful. It's amazing. Cases of headache, for all the cranial nerve issues, for body people who are lazy, who doesn't have enough energy, cranial might help. Cranial help also the academia for the students. They do wonderful. I got so many patients. Actually, his daughter was, I don't know, I should speak or not. I have to take permission first. Okay, I have one of the kids, she didn't get 50% in math after doing the cranial therapy with me. She got 95 or 9 and 100 just by doing cranial therapy. To help the academia. You want to talk about it or no?
Not yet.
Okay, no. Okay, and it helps also the emotional and behavioral. I got a new immigrant mother, coming from Middle East, and her son, she walked into the office with a letter from the school that her son is misbehaving, and the school has to dismiss him. She has to find another school for him. But I told her, bring him here, and she told me that he doesn't pray, doesn't want to go to the Quran classes. They were Muslim, and said, her father get mad at him. I told her, bring him here when I check, maybe he's sick. As soon as I checked his head, he had bizarre cranial rhythm. I told him, your son is sick. He was walking abnormal. Has got a couple of visits actually. He got normal. She came back to the office, and after a couple of visits with a letter from the same school, instead of saying we need to dismiss him, your son's behavior is good now, and we're going to keep him in the school. And she told me that her son tell her, remind me where the Quranic class is, remind me where the prayer time is. Just behavioral. So don't beat the kids, guys. They could be sick. And the proof for that, doctor, we have Dr. Abdelrahman work and all the cranial therapists worked before, many scholars. But in Dr. Daniel Amin book, that a happy 16-year-old girl was riding her bike in a park, and her head hit a tree branch she didn't see. After that, she became suicidal. So I want to tell you here that the brain is like the hardware, emotions, behavior, and feelings are the software. And if you change hardware, you can change software. Change software, you can change hardware. But it's easier if you can change the hardware and change the software, which is emotion behavior. Look at my brother's head here now is less full. Look here, is less full. Now look at this. This was too like inflated. Was like this when it was congested. He now is not as congested, much better than before. See now this was too in, this was too out, and look at here too the same. So this actually cranial work. If you have congestion in your head, can cause the headache. Could be cerebrospinal fluid. Could be a venous blood. You know, that's why we did the transverse sinus release and the foremen magnum opening. Okay, again, leave your comments. Stay tuned. We're gonna give you live cases from my clinic every day. Bye. Dr. Salem from Brooklyn, New York.